I will present today a descriptive study on infections in children with severe acute malnutrition. Although the Sahel region carries a heavy burden of severe acute malnutrition each year, and malnourished children are at increased risk of infections, there is little data on the etiology of infections and on antibiotic resistance in these populations. The children with severe acute malnutrition and a medical complication are hospitalized in specialized centers called intensive therapeutic feeding centers, where they receive empirical treatment based on international guidelines. The high density of patients in these centers, together with the high antibiotic pressure, can favor the transmission and acquisition of multi-drug resistant bacteria. Extended spectrum beta-lactamase carrying bacteria are resistant to third generation cephalosporins and often to most of the commonly used antibiotics. So for all these reasons, we set up a study to describe the infections in children with severe acute malnutrition hospitalized in an ITFC. The main objective of the study was to describe the prevalence of different types of infections and the germs that were responsible for these infections. Secondary objectives included the description of antibiotic resistance of the isolated bacteria, as well as a sub-study on intestinal carriage of ESBL bacteria on admission and their acquisition during hospitalization. There were also other secondary objectives, such as the evaluation of biological and clinical indicators of infection, which I will not have time to present today. The study took place in Maradi, which is a city located in the south of Niger, close to the border with Nigeria. And MSF France, MSF Operational Center Paris, started a nutritional program in Maradi in 2001 that has since included hundreds of thousands of children. The study target sample size was 1,000 children over a period of at least 1 year. And children were included in the study if they were aged 6 to 59 months and were diagnosed with complicated severe acute malnutrition based on WHO standard and were admitted in the intensive care unit of the ITFC. Children were excluded from the study if they were referred from another health structure or had received an antibiotic treatment in the previous 7 days. And every fourth child was included in the sub-study on ESBL carriage. The study was approved by the National Ethics Committee in Niger and the Comité de Protection des Personnes in France, and written informed consent was obtained from parents or guardian. HIV-positive patients were referred to the National HIV Program, and complications that could not be treated at the ITFC were referred to the Maradi Regional Hospital. The clinical examination of the children were recorded in the standardized case report form on admission at day 3 and on discharge and, or at death. In addition, there were a number of systematic analyses that were done on admission on all these children included in the study, a chest x-ray and laboratory analysis including bacterial culture on blood, urine and stool specimens. And other laboratory analysis could be requested based on clinical signs. For every fourth child included in the sub-study on ESBL carriage, a stool specimen was collected on admission and before discharge to look for ESBL carriage and acquisition. And all the systematic laboratory analyses were done in Maradi in the Epicentre laboratory that was set up specifically for the study. Whereas the study on ESBL carriage was done in Paris at Hôpital Bichat. The study started in November 2007 and ended prematurely in July 2008 when the MSF program had to close. In total, 311 children were included in the study. And the population was young with a median age of 13 months. And almost a quarter of the children were from the neighboring Nigeria. 15% of the children presented bilateral edema, And the median weight for height Z-score for the rest of the population of the children with wasting was minus 3.8. Diarrhea was the most frequent clinical sign on admission in more than half of the children, while fever was present in less than half of the children. And a third of the children were lethargic on admission. In average, the children were hospitalized for a duration of 8 days. And the majority of children were transferred to ambulatory care to finish their nutritional treatment. A fifth of the children were discharged home, and 29 children died, which represented less than 10% of the cohort. The main cause of death was sepsis in around half of the children and respiratory tract infection in 15%, and the median time between admission and death was 2 days. All the children received at least one antibiotic treatment, and ceftriaxone was the most frequent antibiotic given, as it was given to 75% of the children. And about a quarter of the children received an anti-malarial treatment. Laboratory analysis confirmed bacteremia in 51 children, or 17%, and gram-negative were the most frequent bacteria, with 19 children with a bacteremia with Salmonella species. And Staphylococcus aureus was the most frequent gram-positive found in the blood culture. 3 Streptococcus pneumoniae were confirmed by bacterial culture, and 3 more suspected. 16% of the children had urinary tract infection, although this diagnosis was very rare on admission. And urinary tract infection were mostly due to E. coli. Smear microscopy confirmed malaria was found in 15% of the children. And among the children with diarrhea, a bacterial etiology was found in 20% and rotavirus in 10%. Respiratory tract infection was detected by chest X-ray in 35% of the children. This graph represents the resistance to the most common antibiotics of Enterobacteria, Salmonella typhi, non-typhi Salmonella, E. coli, Klebsiella species, and Shigella, isolated in the study. And as you can see, most of the Enterobacteria were resistant to amoxicillin and cotrimoxazole, but sensitive to most other antibiotics, in particular to ceftriaxone, and ciprofloxacin. Resistance to gentamicin was low except for Klebsiella species, where resistance was about 40%. All the Staphylococcus aureus isolated in the study were resistant to penicillin G, but sensitive to oxacillin. And the few Streptococcus pneumoniae that could be studied were sensitive to all beta-lactamines. 55 children were included in the study on intestinal carriage of ESBL bacteria, and 17 of these were found positive on admission, giving a proportion of ESBL carriage on admission of 30%. Of the 38 children in whom no ESBL carriage was detected on admission, 16 children had a second specimen collected before discharge and were included in the cohort on ESBL acquisition substudy. 15 of these 16 children had become carriers during hospitalization, giving an acquisition rate of 94% in these children. E. coli was the major species found in this ESBL carriage study, and resistance to cephalosporins was due to the CTX-M15 gene in 90%, and this gene has spread worldwide and is currently the major factor for ESBL carriage in the world. So this study showed limitations, starting with the sample size that was not reached, and this, together with some practical problems, also implied that the sample size for the ESBL carriage substudy was also quite low. In addition, the study period did not cover a whole year, and we missed, in particular, the malaria peak season in Niger, and actually also most of the lean period. Finally, despite all our efforts to reduce contamination, the rate of contamination remained high all through the study, which made the results of blood cultures difficult to interpret, and which might have led to an underestimate of bacteremia, since we might have missed some unusual pathogens that we decided to classify as contamination in our conservative interpretation of the blood culture results. So in summary, we showed a high prevalence of bacterial infections in our study population, with a bacterial infection agent found in 43% of the children. Confirmed bacteremia was found in 17%, but again, the true percentage is probably higher, considering the low volume of blood used and the contamination problem. 1/5 of the children were shown to have urinary tract infection, although these were highly underdiagnosed at admission. And bacterial agents were more frequently found than viral agents in children with diarrhea. Carriage on admission, which is a reflection of the community carriage in this population, was higher than reported elsewhere in the world. And the acquisition was quasi-systematic in the children that were studied here. The bacteria profile suggested that dissemination was probably a major factor. Dissemination in the center was probably a major factor of acquisition, favored by the high antibiotic pressure. And this reinforces the importance of implementing very strict hygiene measures despite technical difficulties in these centers. The quasi-systematic use of ceftriaxone in these children was justified by the high prevalence of invasive bacterial infections, but the antibiotic policy must be reevaluated in light of the results of the ESBL carriage study, as the emergence of these multi-drug resistant bacteria represents a dangerous threat for the antibiotic arsenal available in developing countries. I want to thank all the people who were involved in the study and helped with scientific and technical advice.